Hi, this is Dr. Poole, and I'm going to cover diseases of the breast in this presentation. I'll start off with a discussion of fibrocystic changes and benign tumors. We start with fibrocystic changes because these can clinically and radiographically mimic malignant tumors. So the term fibrocystic change refers to a constellation of benign breast changes that are considered to represent normal but exaggerated hormonally mediated breast tissue responses. Fibrocystic changes generally affect premenopausal women and is the most common cause of a breast lump in females under 50 years of age. Surgery rarely, if ever, has any role in the management of fibrocystic changes, other than sometimes to provide a definitive histologic diagnosis in the investigation and treatment of a suspicious breast mass or radiologic lesion. As the name would suggest, breast tissue that demonstrates fibrocystic changes will generally show fibrosis with blue dome or clear cysts that may range in size from less than 1 millimeter to greater than 2 centimeters in diameter. These changes are variable in their extent and in how they're mixed together, but are usually multifocal and bilateral, involving both breasts. The characteristic histologic changes of fibrocystic changes include stromal fibrosis, dilated or ectatic ducts with cyst formation, apocrine metaplasia, and mild usual epithelial hyperplasia without atypia. So this is the typical gross appearance that we see with fibrocystic changes. We have these irregular white areas, which are the areas of stromal fibrosis, and you can see the clear cysts, which are also present, and they range quite a bit in their size and shape. And histologically, we see these variably sized cysts or cystically dilated ducts, and these cysts are lined by very eosinophilic cells, which are called apocrine metaplasia. You can even see some tufting up the epithelium, indicating some slight hyperplasia. It's important to note that there is no increased risk for the subsequent development of breast carcinoma in women with fibrocystic changes. The non-surgical treatment consists mainly of hormonal manipulation, with the goals being to provide symptomatic relief from breast pain or tenderness and to prevent progression of the cysts and fibrosis. As mentioned, surgery rarely, if ever, has a role in the management of fibrocystic changes. Okay, let's talk about benign tumors of the breast. First is intraductal papilloma. Papillary lesions of the breast are characterized by the presence of finger-like fibrovascular stromal cores lined by epithelium, forming papillae. They involve true ducts, hence the name intraductal. Intraductal papillomas can be solitary or they can be multiple. Solitary or centrally located papillomas, which are more common, are usually located beneath the areola, whereas multiple or peripheral papillomas are often peripherally located in the breast. Usually multiple papillomas are clustered together, or at least regional, and are continuous with hyperplastic alterations in adjacent lobular units. Centrally located papillomas may be associated with a bloody or clear nipple discharge, or may even be palpable, whereas multiple papillomas are more likely to be clinically occult and identified by biopsy for some other reason. These lesions show a wide variation in size, from microscopic foci that are discovered incidentally to up to 10 centimeters or greater in largest dimension. They're typically well-circumscribed tumors and may vary from soft to firm depending upon how much stromal fibrosis is associated with the center of the papilloma. Histologically, they're composed of multiple branching papillae lined by myoepithelium and epithelium, so the normal bilayer, with varying degrees of epithelial proliferation as well as stromal fibrosis. The epithelium may be modified to show usual or even atypical ductal hyperplasia or apocrine or squamous metaplasia. So this is a fairly typical intraductal papilloma. Note that these are well circumscribed lesions, and you can see a portion of the duct that's involved here at the bottom. So this is a lesion that's projecting into and dilating the duct. You can see the central fibrovascular core, which radiates, forming these papillae, which can be quite complex in their architecture. This is just another intermediate power view, showing again the circumscription, the lesion that's filling the duct, and the fibrovascular cores forming these papillae. You can see the fibrovascular cores here, and the epithelial projections sticking out. As mentioned, the center of these papillomas can sometimes undergo stromal fibrosis, and in this case the lesions would appear radiographically more dense and possibly therefore more suspicious, and if they're large enough may be firm to palpation and even discovered by the patient. And histologically you can see the usual bilayer of cells, so these clear cells closest to the stroma are myoepithelial cells, and you have some mildly hyperplastic duct epithelium. Usually these are associated with mild usual type epithelial hyperplasia without atypia. Patients with solitary papillomas without atypia have a twofold risk of developing breast cancer, and those with multiple papillomas without atypia have a threefold increased risk. The relative risk of breast cancer in patients with solitary and multiple papillomas with atypia, however, increases to 5- to 7-fold respectively. So surgical excision is generally recommended unless the papilloma represents an incidental finding or has been completely excised during a core biopsy. In papillomas with atypia, however, complete excision with careful clinical follow-up is warranted because of the increased risk of an associated breast carcinoma in the future. The next two benign tumors that I'll talk about are fibroadenoma and Pathologies tumor, which are grouped together as fibroepithelial lesions. Now, this means that these tumors are composed of both stromal and epithelial elements. Fibroadenomas are generally recognized to be hyperplastic lesions, but Pathologies tumors are truly neoplasms. Fibroadenoma is the most common benign tumor of the breast and presents as a mobile, painless, well-defined breast lump, particularly in women in their 20s and 30s, although they can be found in women of any age. Fibroadenomas are usually solitary, but in some patients can be bilateral, or even multiple lesions can be seen. Grossly, these are well-defined firm masses. They generally range 1 to 3 centimeters in greatest dimension, but rarely can be quite large lesions. They're often identified by the patient because they are firm in quality and thus more easily palpable. They tend to be round to ovoid on the cut surface. They're often gray with no true capsule. They have a rubbery cut surface because of the stromal component, and are often lobulated with slit-like spaces, which is the epithelial component. Occasionally they can even be soft and have a myxoid stroma. But generally, as the patients age, the lesions develop more stromal fibrosis and have a sclerosed, sometimes even hard or gritty texture. Microscopically, the stromal component is loosely cellular and completely lacks cellular or cytologic atypia or mitoses. The epithelial component consists of compressed ductal structures or tubules with myoepithelial and epithelial layers. They can show on occasion epithelial hyperplasia and rarely atypical hyperplasia, lobular neoplasia, or even ductal carcinoma in situ. So this is a very typical gross appearance. Again, these are well circumscribed, and they have this lobulated type of appearance, meaning the tumor forms these lobules. And you can see some cleft-like spaces, which, as we'll see microscopically, represent the epithelial forms. Fibroadenomas are also associated with a variety of different epithelial configurations. The epithelial component can consist of these long curvilinear interlocking ductal structures, or can have a more tubular type of appearance where the tubules appear in clusters like you see in panel D. Importantly, the epithelial component consists of the normal bilayer of an inner layer of secretory type epithelial cells and an outer layer of myoepithelial cells, which is well demonstrated by the arrows in this picture. And this shows the well circumscribed part of the tumor. It has this fibrous capsule around it and a pushing type of border. And the epithelial component consists of these, in this case, these long, slender, interlacing slits, as well as these more tubular type structures which tend to be arranged in loose groups. The background cellularity is still relatively loose, and if we looked at high power, we would see no stromal cell atypia. Pathology's tumor is the true fibroepithelial neoplasm. So it's composed of both epithelial and stromal components, but it's the stromal component that gives it its unique features. These are uncommon tumors, less than 1% of all breast tumors, and only about 2.5% of all fibroepithelial lesions in general. So fibroadenomas are much, much more common. One distinctive thing clinically is that these are most common in women in their 50s, although they can occur in any age and rarely occur in young women even. Also, a distinct difference with fibroadenomas are that these are clinically rapidly growing lesions, but still are typically well-defined masses and mobile and non-tender. Pathology's tumors are a challenge for pathologists because it's difficult to predict the prognosis. The majority of them are benign, but uncommonly they can show malignant features and have the capacity of metastasizing. There's a even higher incidence of these recurring. About 15 to 20% recur after surgical excision, although the incidence of recurrence is dependent upon the completeness of excision. So as opposed to fibroadenomas, which can be easily shelled out from the surrounding tissue, Pathology's tumors should be excised with a margin of normal tissue. These also show a wide variation in size, ranging from a few centimeters to really huge lesions that occupy much of the breast. Like fibroadenomas, they're well defined and often lobulated, but in malignant lesions, the borders become more ill-defined and infiltrative. The cut surface shows elongated clefts with a tan or gray-brown whorled stroma. The stroma appears different than in fibroadenomas because of increased cellularity. Microscopically, the glandular component is vaguely similar to that seen in fibroadenomas, except for the glands tend to form leaf-like structures, and this is a key term or buzz term that's used that might be like a step one type of term. So leaf-like structure of the glandular component is associated with Pathologies tumors. Now, benign lesions, the stroma is more cellular than what's seen in fibroadenomas. You may see mild to moderate cytologic atypia and a few mitoses, but the margins are still well defined and there's no overgrowth of the stroma. In malignant lesions, however, there's overgrowth. That means that most of the tumor is composed of atypical stromal cells with numerous mitoses, more than 10 per 10 high power fields, and sometimes you can see heterologous sarcomatous elements such as chondrosarcoma or rhabdomyosarcoma developing within the stromal component. So those are truly malignant mesenchymal type neoplasms or sarcomas. So this is an example of a benign Pathologies tumor. Again, note how it's well circumscribed. It has a fibrous pseudocapsule again, and it's still composed of an epithelial component as well as a stromal component. So you have to look for other features and at high power to identify a Pathologies tumor. So we see these characteristic leaf-like projections of stroma and epithelium here. So they're more broadly shaped and sort of project into the spaces around it. So leaf-like projections, remember that. And at high power, notice that the tumor stroma is much more cellular than what we see in the fibroadenoma. So the main microscopic difference between fibroadenoma and Pathologies tumor is the increased cellularity of the stroma. As you get to tumors that show more and more features of possibly behaving in a malignant fashion, then you see increasing cytologic atypia as well as mitotic activity. All right, the rest of this presentation will deal with breast cancer itself. So the incidence rates of breast cancer were about 266,120 new cases in 2018. This represents about 15.3% of all cancers. It's the most common female cancer and the second most common cause of cancer death. The incidence rates decreased from 1999 to 2007 by about 1.8% per year. It's likely that two factors have contributed to this decline: the discontinuation of hormone replacement therapy and the saturation or leveling off of screening mammography rates. It's interesting that of these factors, discontinuation of hormone replacement therapy has been shown to be having a greater effect. Because of improved treatment and early diagnosis, the 5-year survival rate between the years 2008 and 2014, the last reported, has been estimated at about 89.7%, which is excellent. There's a variety of different risk factors for breast cancer. It's important to remember that breast cancer also occurs in men, but female gender is certainly a risk factor in and of itself. The risk of breast cancer increases with older age. The probability increases from about 1 in 51 females from birth to age 49 to 1 in 15 females in age 70 and older. The overall probability is 1 in 8 females from birth to death. African white race is another risk factor for breast cancer. African American females more commonly present with regional or advanced stage disease, and have a higher breast cancer-specific mortality rate. Obesity is another risk factor associated with breast cancer. High endogenous estrogen levels also increase the risk of both postmenopausal and premenopausal females. Family history of breast cancer is another significant risk factor. The risk associated with a positive family history is strongly affected by the number of female first-degree relatives with and without cancer. In the United States, most patients present due to an abnormal mammogram. Up to 15% of women, however, are diagnosed with breast cancer due to the presence of a breast mass that is not detected on mammogram, and so this is called mammographically occult disease. Another 30% present with a breast mass in the interval between mammograms, which we call interval cancers. The classic characteristics of a cancerous lesion include a hard, immovable, single dominant mass with irregular borders. However, these features cannot reliably distinguish between a benign and malignant tumor, as we kind of discussed with fibrocystic changes. The signs of a more advanced local regional disease include axillary adenopathy, which suggests metastasis to local lymph nodes, and skin findings such as erythema, thickening, or dimpling of the overlying skin, which we call a peau d'orange or orange peel effect, which suggests inflammatory breast cancer, which I'll talk about a little bit later. Symptoms of metastatic breast cancer depend on the organs involved, of course, with the most common sites being the bone and association with back or leg pain, liver, which may be associated with abdominal pain, nausea, or jaundice, and lungs, which may be associated with shortness of breath or cough. As I mentioned, breast cancer does occur in men. In the United States, male breast cancer represents about 0.5 to 1% of all breast cancer diagnosed each year. Breast cancer in men accounts for less than 0.5% of all cancer in men, however. As with breast cancer in women, a family history of breast cancer in a first-degree relative is associated with an increased risk of breast cancer among men. The risk of male breast cancer also appears to be higher with inherited BRCA2 rather than BRCA1 mutation. Although most histologic types of breast cancer are seen in women also present in men, men with breast cancer are rarely diagnosed with lobular carcinomas because men don't develop breast lobules generally. So this is an outline for the pathology of breast cancer that I'll continue with. There are ductal carcinoma in situ lesions, which are non-invasive, invasive ductal carcinoma. There's a few histologically distinct or special types that you should be aware of: tubular carcinoma, mucinous carcinoma, and medullary carcinoma. There's a clinically distinct type, which we call inflammatory carcinoma. And then there's the lobular carcinomas. Lobular carcinoma in situ, which again is a non-invasive lesion, and invasive lobular carcinoma. So let's talk about some pathology. So, ductal carcinoma in situ represents a malignant proliferation of epithelial cells, but that are confined to the duct system, and there's no evidence of stromal invasion. This is a common lesion, and up to 25% of screen-detected breast carcinoma is ductal carcinoma in situ, or DCIS. DCIS may arise anywhere in either breast, and is best thought of as a precursor lesion of invasive carcinoma, although not every case will progress. DCIS is most commonly recognized because of its association with microcalcifications, which are identified on breast screening mammography. It can also present as a mass. It could present as Paget's disease of the nipple, or rarely be associated with nipple discharge. Treatment is usually by wide surgical excision with a rim of surrounding benign breast tissue. Much less commonly, a mastectomy may be performed. Radiation therapy following wide local excision is presently advised for most cases. The role of hormonal therapy is more controversial, and I won't discuss that any further. Often DCIS is not grossly visible. Occasionally it may be identified grossly by speckled, ill-defined area in the breast tissue, which is a result of comedo-type necrosis, which I'll talk about in a minute, and associated calcifications. Microscopically, DCIS is characterized by an epithelial proliferation within the ducts, although this may extend to lobular structures, but is still confined within the ductal lobular system and is referred to as cancerization of the lobules. There's a wide variation in the appearance of the neoplastic cells, which may be large and pleomorphic, forming a solid growth pattern, which we see in high-grade DCIS, or small and regular type cells showing polarization around architectural structures, forming such things as micropapillae or cribriform spaces, which are more associated with low-grade disease. Common to everything is that there's no invasion through the basement membrane. So this is an example of low-grade DCIS. You can see that there's cystic expansion of these ducts, but as opposed to fibrocystic changes, they're lined by multiple layers of cells and form these punched out structures here, which we call cribriform, meaning sieve-like. This is just a higher power view, again showing this cribriform type architecture as well as these slender micropapillae. Even at this power you can see the nuclei, and these cells are larger than normal luminal or secretory type ductal epithelial cells. We'll see this a little bit more in high power. This is an example of high-grade DCIS. Notice the solid growth pattern with a central area of necrosis, which we call comedo necrosis mainly because of its gross feature. As I mentioned before, you can sometimes see this, and it reminded early pathologists of skin comedones or whiteheads, because you can express this necrotic material from the cut surface of the breast. And in high-grade DCIS, we see even more pronounced nuclear enlargement, pleomorphism, and you can readily identify mitotic figures within the neoplastic epithelium, but it's still confined to the duct. The majority of invasive ductal carcinomas are of no special type, meaning that in essence microscopically the tumors show such variable combinations of morphology that prevent them from being allocated to a particular or special type. Grossly, these are usually firm. They can be well to poorly demarcated, but most often form a stellate infiltrative type mass. There's a wide range in sizes at presentation, from a few millimeters that may be detected incidentally through mammographic screening to huge tumors that may be unfortunately ignored by the patient until they occupy most of the breast. Microscopically, these may form trabecular, sheet-like, acinar or glandular or nested type of patterns. More than 50% of the tumor shows these no special type patterns. The stroma may be desmoplastic or collagenous, and there may be minimal stroma. The tumor cells also show a variable degree of differentiation, and this is reflected in how the tumors undergo histologic grading. A patient's survival following diagnosis of invasive ductal carcinoma of no special type is dependent upon the traditional prognostic factors such as histologic grade, the stage of the lymph nodes, the tumor size, the presence of lymphovascular invasion, as well as the effectiveness of the appropriate therapy. In this example of an invasive ductal carcinoma that's low grade, it's predominantly composed of these small solid nests and larger trabeculae or bars of tumor, as well as these small glandular type structures. Notice all the pink and pink blue material forming the desmoplastic reaction to the tumor, and note the infiltrative stellate edge of the infiltrating margin. This is a high-grade invasive ductal carcinoma, and you can see that it predominantly is composed of these solid bars and nests of cells. There's not a lot of gland lumina formation, and the inset shows higher nuclear grade with easily found mitoses and marked nuclear atypia. It's important to be aware of some special types of invasive ductal carcinoma. These are a time-honored favorite of Step 1 type questions. Tubular carcinoma, you can see, is an uncommon form of invasive ductal carcinoma, only occurring or only diagnosed as in about 1 to 2% of all invasive carcinomas. By definition, it shows discrete tubules, and also by definition, it has to occur in over 90% of its morphology to be diagnosed as tubular rather than just the invasive ductal carcinoma of no special type. Grossly, these are moderately well defined. They do have a microscopic invasive front and a typical stellate gray cut surface, which is common to most breast carcinomas. Microscopically, the key finding is angulated small tubules which are lined by a single layer of neoplastic or malignant epithelial cells. Oftentimes the cells cytoplasm form these apical snouts or little budding on the luminal aspect of the cells, and usually these are associated with a robust desmoplastic fibrous stroma. Now, the most important thing to remember is that these have a better prognosis than invasive ductal carcinomas of no special type. The rates of both local and systemic recurrence are lower for patients with tubular carcinoma compared to age-matched stage-for-stage controls. So microscopically, again, these typically do have an invasive front, although they are moderately circumscribed, and the tumor is composed of these small tubules with abundant desmoplastic stroma in between. When we look at higher power, these tubules are composed of a single layer of malignant cells. Sometimes you'll hear them referred to as teardrop shaped because the tumors, these tumor glands are kind of compressed by the surrounding desmoplastic fibrous stroma. Again, these form a single layer of neoplastic epithelial cells, and sometimes you can see these little apical snouts associated microscopically with the neoplastic glands. Another distinctive histologic type is mucinous carcinoma. These are characterized by mucinous morphology in over 90% of the lesion. There's a wide range of incidence because the definition of what percentage was necessary to call it mucinous carcinoma varied over the years. But it's also generally about 1 to 2%, although the range that you'll find in the literature is slightly wider. Now, grossly, these are well-defined masses, but they have a gelatinous, not a fibrous cut surface. Microscopically, These are well circumscribed but unencapsulated masses, and the key finding is nests or trabeculae of neoplastic cells that appear to be floating in lakes of mucin. The tumor cells themselves show mild to moderate nuclear pleomorphism, and most importantly, these have a better 5-year disease-free survival rate compared to age-matched controls with invasive ductal no special type carcinomas. So they behave better than the usual no special type carcinomas. So this is the characteristic appearance. They tend to be well circumscribed masses, and most of the tumor is actually composed of this mucin material that is dissecting in between the surrounding stroma. And the malignant cells are these small nests. Sometimes they form these complex glandular cribriform structures, but the tumor cells appear to be floating in the mucin. On higher power, the cells within these islands of tumor are small and show usually mild nuclear pleomorphism, so they're low grade. And finally, of the pathologic distinct types is medullary carcinoma. This is an uncommon or even rare variant representing less than 1% of invasive breast carcinomas, but this is very variable upon the strictness of the application of diagnostic criteria. These are also usually well circumscribed, well-defined masses and have a gray tan cut surface. They can mimic clinically fibroadenoma. Microscopically, these have 3 key features. A solid growth pattern where the tumor cells are arranged in syncytial sheets, by definition, this arrangement is in more than 75% of the tumor. Another key feature is that these have a moderate or marked lymphoplasmacytic infiltrate, and this is a key feature of the tumor. And finally, the tumor cells themselves have high-grade or marked nuclear pleomorphism. These are also characteristically negative for estrogen and progesterone receptor expression. These also are said to have a favorable prognosis compared to the no special type, especially when the diagnostic criteria are strictly applied. So microscopically, you see in panel A on the upper right that these are well circumscribed, and the bottom shows this the architectural features of the tumor cells arranged in a solid sheet, which is outlined in blue, and then accompanying the tumor is this characteristic lymphoplasmacytic stroma. Finally, I'll talk about inflammatory breast carcinoma, which is not a distinctive histologic type, but is a distinct clinical entity that's characterized by diffuse redness or erythema and edema of the breast skin involving a third or more of the skin of the breast. And this combination of redness and edema produces an orange peel or peau d'orange type of effect. This is about 2.5% of all breast cancer cases, and the diagnosis is based upon these clinical criteria. 1, rapid onset, usually less than 6 months of breast redness, edema, and or this orange peel effect, and or breast that feels warm. The erythema has to occupy at least a third of the breast, although usually it involves the entire breast. And the third component is that there's pathologic confirmation of some form of invasive carcinoma. So primary inflammatory breast carcinoma has some characteristic biologic features as well. Number 1 is its rapid progression. It's also highly angiogenic and angioinvasive, meaning that the tumor cells have a special propensity for blood vessel invasion, and this accounts for high metastatic potential in these tumors. These show aggressive behavior and angiogenicity, and these are intrinsic features to this clinical form of breast carcinoma. The classic histologic findings of IBC on biopsy of affected skin is dermal lymphatic invasion by tumor cells. This change can even be seen in areas of the skin that are clinically normal. The malignant cells form tumor emboli, which are responsible for both the local signs and symptoms of the disease, as well as the biological development of metastatic disease. So the term inflammatory is actually a misnomer because the clinical signs suggesting inflammation, that is redness, edema, are not due to inflammation but are due to the infiltration of lymphatic and blood vessels by tumor cells, not inflammatory cells. The absence of dermal lymphatic invasion, however, does not exclude a diagnosis of inflammatory carcinoma in patients who otherwise clinically have the characteristic mammary skin changes and also demonstrate invasive carcinoma of the underlying breast. In other words, dermal lymphatic invasion is usually seen but is not necessary for the diagnosis. And so on the left is a mastectomy specimen showing some of the clinical signs and symptoms of inflammatory carcinoma. Notice that in the areolar region the nipple is inverted, meaning that it's pulled down beneath the skin surface. And notice the redness and the lumpy, bumpy quality to the breast skin here, as well as over here. And then histologically, what we see is a section of skin here in which the dermal lymphatics are dilated because there are tumor emboli sitting in these spaces. For comparison, here's an empty dermal lymphatic space. The other main category of breast cancer is lobular carcinoma. So lobular carcinoma in situ is characterized cytologically by discohesive or disheesive uniform cells that have eccentric nuclei and frequently show prominent intracytoplasmic mucin vacuoles, giving the cells a signet ring type of appearance. LCIS is basically best seen as a generalized risk factor for the subsequent development of breast cancer. So the relative risk of associated invasive carcinoma is about 4 to 5 times for so-called atypical lobular hyperplasia, but goes up to 8 to 10 times for LCIS. It has no specific clinical features. This is usually an incidental finding when a biopsy is performed for microcalcifications or some other subtle mammographic finding. The treatment of classic atypical lobular hyperplasia and LCIS is surgical excision, which is aimed at risk reduction and includes close observation. Sometimes the use of selective estrogen antagonists is recommended as well. And histologically, what we see in LCIS is distension of involved lobules by disheesive uniform round cells with eccentric cytoplasm. The cells frequently contain intracytoplasmic mucin, again giving it a targetoid type appearance. The cells are uniform with no pleomorphism and are small. They're about 1 to 2 times the size of normal lymphocytes and just slightly larger than lobular epithelial cells are normally. So what we see histologically is a terminal duct lobular unit in which the lobules are enlarged by this neoplastic proliferation. You can actually see here too the neoplastic cells going out into the duct. Notice that the duct lining appears thicker than normal, and these are neoplastic lobular cells invading laterally into the ducts. Here's a higher power view in the bottom panel showing the small nuclear and small cell size shape and the uniform regular nuclei. Invasive lobular carcinoma represents about 5 to 15% of all invasive breast carcinomas. Grossly, there's a wide variation from discrete, firm gray masses to poorly defined areas of thickening that don't really form a discrete mass. Microscopically, the cells show a disrhesive pattern of infiltration with single cells and linear single-file arrangements of cells. The cells are small and lymphocyte-like with oval nuclei, minimal cytoplasm, but sometimes intracytoplasmic lumina. Lobular carcinoma is also frequently present. By immunohistochemistry, the key finding is a negative or reduced staining for E-cadherin, which is a cell adhesion molecule and accounts for the disrhesive pattern of growth. These are usually positive for both estrogen and progesterone receptors. And histologically, what we see in invasive lobular carcinoma are these single cells, or sometimes small groups of cells. Sometimes they're arranged in these linear arrangements. And just for comparison, here's a benign duct in the middle. These diffusely infiltrate into the stroma in this disrhesive type of pattern. And this is just a higher power view to emphasize again this single cell infiltration and arrangement of the cells in these linear single file arrangements. Also, you can note that these are small cells with scant cytoplasm and have fairly uniform oval to round nuclei. The diagnosis of breast cancer also includes the evaluation of additional prognostic or predictive markers. So we test tumors for estrogen and progesterone receptor expression and expression for the epidermal growth factor HER2 or HER2. Estrogen and progesterone receptors are prognostic factors, especially for the first 5 years after diagnosis. They're also predictive markers for the appropriateness of anti-estrogenic or hormonal therapy. And we determine ER and PR expression by immunohistochemical staining on tumor tissue. HER2 overexpression is present in about 20% of breast cancer patients, and this is a predictive marker for response to HER2-targeted therapy, such as trastuzumab. We also determine HER2 expression in two ways. We can look at it by immunohistochemical staining of tumor tissue or by detection of HER2 gene amplification by fluorescence in situ hybridization, or FISH. To end with the discussion of breast cancer, modern diagnosis recognizes molecular subtypes based on the efforts of the Cancer Genome Project. And so breast cancer is being increasingly thought of in terms of molecular subtypes. The first is, and most common subtype, is the so-called luminal type. And this gene expression of these types of tumors are most closely resemble the normal breast luminal epithelial cells. So these are estrogen receptor positive. They may be HER2 positive, but these have the best prognosis of all the molecular subtypes. There's another subtype that's HER2 enriched, which accounts for about 10 to 15% of all breast cancers, in which there's high expression of HER2. Usually these are negative for estrogen and progesterone receptors. The worst molecular subtype is a so-called triple negative subtype, or basal subtype, and this genetically most closely resembles basal epithelial or myoepithelial cells. So these are negative for estrogen and progesterone receptor and for HER2. Some of these, this is not a uniform subtype. Some of them show features of more myoepithelial expression, while others are just negative for everything. It's interesting that African American women have been shown to have an increased propensity to develop these basal type or triple negative tumors. So that ends long discussion of breast diseases, especially breast cancer. I know it's a lot to digest, but this is a very important topic to know about as you go forward in your studies. So thank you.